Hi, this is the voiceover PowerPoint for tissue integrity and integumentary functions. With regards to the functions of the skin, when reviewing the anatomy and physiology, it's very important to review the 6 functions of the skin, which are protection, sensation, fluid balance, temperature regulation, vitamin production, and immune response function. Regarding protection, review the 3 layers of the skin and the rows, which are epidermis, dermis, and subcutaneous fatty tissues. Know one of the major functions of the skin, which is to effectively protect against invasion of bacteria and other foreign matters. Regarding sensation, just being aware that the skin has receptors, endings of nerves that aids in temperature control, pain, light touch, and pressure or heavy touch. Remember, a patient can feel pain, pressure, and temperature. Nurses can feel patient's temperature. Be mindful that we have nerve endings all over our body, but more concentrated in the head and the distal extremities. Therefore, patients have an increased sensation in the head, fingers, and toes. As far as fluid balance, nurses must understand that we can lose and or gain fluid through the skin. The skin can absorb water to prevent excess loss of fluids and prevent one from becoming dehydrated. The average sized person can lose about 500 mLs of water daily through sweat and diaphoresis. This is called insensible losses. Insensible losses cannot be measured as an output and can vary depending on the person. They can have a fever or an increased temperature. Continuing with the 6 functions of the skin. Temperature regulation. So the person's body produces heat through activity. As the person increases the activity, the more heat is lost. Sweating is another process by which the body can regulate the rate of heat loss. The skin can maintain, regulate, or release heat based on our activity. Our normal body temperature is 98.6 Fahrenheit or 37 Celsius. Sweating does not occur until the core body temperature exceeds the normal body temperature of 98.6 Fahrenheit or 37 Celsius. Under some circumstances, such as emotional stress, sweating may occur as a reflex and may be unrelated to the need to lose heat from the body. When looking at vitamin production, nurses must understand that when people are exposed to sunlight and that sunlight converts vitamin D to its active form, vitamin D is essential for preventing osteoporosis and rickets, a condition that causes bone deformities and results from deficiency of vitamin D, calcium, and phosphorus. As far as immune response, nurses must understand that the skin not only protects people against harmful infections, but it also triggers an immune response when exposed to certain antigens. During the integumentary assessment or any physical assessment, nurses must obtain a thorough health history as well as observation. Nurses must do a physical assessment, understanding the anatomy and functions of the skin, recognize the deviations from normal, report it, and document their findings. For example, if a patient comes in with integumentary issues such as pruritus, which is itching, the nurses will get a thorough health history on that patient and do a physical assessment. The nurse will ramp up her or his skin assessment by asking the patient different questions regarding the skin assessment. For example, the nurse will ask, when was the onset of symptoms? Any changes in lotions, soaps, or detergent use? Do you have a history of hay fever, asthma, hives, eczema, or allergies? These questions are normally not asked during an average patient routine head-to-toe assessment. Nurses just need to think about what is entailed during a physical skin assessment and also recognize any areas where the skin may not be intact, including bruises, ecchymotic areas, hematoma, abrasions, lesions, and note anything out of the ordinary. Also included in the skin assessments are the hair, scalp, nails, and mucous membranes. There's a list of questions listed in your book nurses can ask during obtaining a health history on skin disorders. Assessing skin color. When assessing skin color, please note that people with dark skin, melanin is produced at a faster rate and in larger quantities than in people with light skin. Healthy dark skin people have a red based undertone. The color shades that occur in people with dark skin are largely determined by genetics, and they can be described as light, medium, or dark. Students need to be familiar with following terms that are located in a PowerPoint, such as cyanosis, which is a bluish tint color, and it reveals poor circulation or decreased oxygenation in the blood. In a person with a dark skin, the skin usually is more of a grayish color. Jaundice color is that yellowish orange in color, and it reveals hepatic or liver problems. In a dark skinned person, if you look at their sclera, the white of their eyes, in some patients it might be noted to be jaundice or yellow in color, if that patient has some type of hepatic problem going on. Do not mistake normal yellowish fatty deposits in the periphery under eyelids for jaundice. Erythema refers to redness. In people who are light-skinned, it is easily observable. Dark-skinned people tend to assume a purple-grayish color when an inflammatory process is present. It may be difficult to detect erythema. There's a table in your book that lays out various color changes in light and dark-skinned people. As an instructor, I do not want to get more into depth with this, but nurses must know where there are different color changes in patients in light and dark skinned people. When assessing skin rash, nurses need to remember that when assessing patients and they note that there is a rash, the nurse needs to palpate that rash and of course wear gloves. The nurse needs to know if the skin is raised or elevated in any way. Again, we must note any itching. We need to take their temperature. We need to feel the rash with our hands to see if there's any warmth coming from it. Primary and secondary lesions. Assessing skin lesions. Nurses need to know the difference between primary and secondary lesion. Primary being the initial lesions and have the characteristics of the disease itself. Secondary lesion is the result from external causes such as scratching, trauma, infections, or changes caused by wound healing. For example, a primary lesion could be a pustule noted from having chickenpox. Pustule is a pus field or lesion. Secondary lesion would be from the result of scratching it, By scratching the primary lesion, it developed an infection and spread to other areas. So the scratching within itself would be the secondary lesion. Nurses need to understand or identify the different lesions, and those are noted in your book. We have provided an additional handout listed in the resource section in Ivy Learn in your class section. The handout lists various lesions, provide definitions or examples of the various lesions. The handout also provides textbook pictures as well as real human pictures, so you would need to be able to identify those various lesions if you were asked to identify an image or write a narrative note. Normal skin aging. In your reading, it discusses normal skin aging and changes associated with aging. You would need to read that. Having a good understanding of the different changes that someone goes through when their skin ages. Some normal skin aging changes are dryness, wrinkles, thinning of the skin, loss of subcutaneous tissues, which is the adipose or fat tissues, uneven pigmentation, decreased muscle tones. So go ahead and read that further in your textbook. Integumentary assessment on hair, scalps, and nails. This section on hair, scalp, and nails is a self-study. The term clubbing of the nails is associated with pulmonary disease and can be a sign of chronic hypoxia. There's a picture that identifies what clubbing may look like. You can also Google clubbing of the nails to gain more images and knowledge as to what clubbing is. So go ahead and continue to read this as a self-study. Integumentary assessment on pressure ulcer. Pressure ulcer is a preventable condition if not cared or treated properly, can cause patients and healthcare facilities millions of dollars each year. Pressure ulcers are where soft tissues are compressed between bony prominences and external hard surfaces. They are caused by unrelieved mechanical pressure in combination with friction, shearing forces, and moisture. In Ivy Learn in your class under resources, there are additional information provided. It would be also very beneficial to go back and review any information from your fundamentals class you may have gained with regards to pressure ulcers. Risk factors. There are several risk factors noted in your reading and on the fun sheets provided. This will be reviewed in class. Signs and symptoms. Looking for the first sign of a pressure ulcer will be the skin will be blanchable and then erythema, which is redness, and it progresses to non-blanchable. Patient may or may not experience pain with these pressure ulcers. In the next few slides, we will be looking at stages of ulcers. Diagnostic testing. Diagnostic testing is usually not done to identify pressure ulcers. Once the ulcer have developed, the physician may do a CBC, a blood test to look for the white blood cell count to check for an infection. Doctors may also order wound cultures to check for an infection, but to also identify organisms that have invaded the area. Antibiotics may be ordered based on what organisms have been identified. Geriatric considerations. Please review the geriatric considerations. We as nurses need to look at the nutritional factors that play into pressure ulcers and delay wound healing. Factors such as patient would need an increased amount of protein in their diet to assist in wound healing and the prevention of skin breakdown. Integumentary assessment on pressure ulcers and nurses' roles. Nurses need to be able to identify pressure ulcers and bony prominences area that put one at greater risk for pressure ulcers. Ulcer classification. Nurses must be able to identify the different stages of ulcers. For instance, stage 1 is considered non-blanchable, skin is intact, redness is noted. In a dark-skinned person, you may note the skin may be reddish and have bluish purple in color. Patient may feel pain at this stage. Stage 2, there's loss of dermis and epidermis. This is considered partial thickness wound. It may present as a shallow open ulcer with red, pink wound bed without slough. Stage 3 is classified as the loss into the subcutaneous tissue or in the fatty tissue, and is considered the full thickness. In stage 3, the subcutaneous fat may be visible, slough may be present, and it may include undermining and tunneling. Stage 4 is damage involving the muscle, tendon, and possible bone. This is also full thickness as well. Slough or eschar may be present on some parts of the wound and often include undermining and tunneling. And then there is unstageable wounds, which are also classified as full thickness. Unstageable wounds may be covered with eschar, and it's very difficult to understand what might be happening under that eschar. That's why they might consider it as unstageable. Examples of pressure ulcers. These are again examples of different stages of pressure ulcers. Stage 1, 2, 3, and 4 on this slide, and your book have additional examples. I also cannot stress enough the need for protein for wound healing, especially when a patient is presented with a pressure ulcer. Integumentary assessment, nursing interventions in regards to pressure ulcers. With regards to nursing interventions, a lot of this involves around assessment. You have comprehensive pressure ulcer assessments and risk assessment that should be done on all patients. The initial assessment always requires a registered nurse, which is about 1 to 2 RNs. Reassess risk daily. Nurses do reassess risk daily by the way of braiding scale. We will discuss braiding scale in the next slide. Inspect all skin daily. Nurses do head to toe assessment daily, which include inspecting the skin. Some facilities require nurses to reassess and document their head to toe assessments on their patients twice a day or every 4 hours. As a new nurse coming on duty, you will want to know the condition of the patient's skin because you never want to own something you did not do. Manage moisture. Nurses must manage moisture of the skin, must assess the skin for moisture, dryness, and flakiness, and provide proper intervention such as skin care, toileting, bathing, hygiene, and the use of lotions or skin barriers. Optimize nutrition and hydration. Nurses again must assure that the patients are receiving enough protein for wound healing and providing proper prevention of skin breakdown. Nurses again must know accurate intake and output, which is very important and is very imperative to assess the client's hydration status. Minimizing pressure by turning the patient every 2 hours, or moving or shifting the patient every hour if the patient is in the chair. Nurses need to minimize pressure by various interventions. If the patient is in the chair, the nurse must encourage them to shift position every hour. When the patient is in the bed, the nurses need to assist with turning every 2 hours. If the patient can turn themselves, the nurses need to remind them to reposition and turn to minimize the potential of skin breakdown. And then finally, using their pressure relieving devices such as specialized wheelchair cushions, specialty beds, or alternative bed surfaces may be indicated to help relieve the pressure on the skin. Braiding scale. So the braiding scale is a valid tool used to assess pressure ulcers in patients at risk for pressure ulcers. This tool is commonly used in hospitals in the United States in a variety of settings. Many facilities may ask nurses to use the braiding scale daily when doing their head-to-toe or physical assessment. Again, the braiding scale is listed in your book. The braiding scale looks at different items when scoring, such as sensory, moisture, activity, mobility, nutrition, friction, and shear. And at the bottom, you will see the number scoring to see if the patient is at high, moderate, low risk for developing pressure ulcers. This slide is just an example on how nurses will apply the braiding scale to an actual patient. So in your previous slide, you saw that the braiding scale and how you add everything up to determine if the patient is at low, moderate, or high risk for developing a pressure ulcer. Integumentary diagnostic testing. You need to review your diagnostic testing with regards to integumentary. Biopsies. Biopsies are performed to obtain tissue for microscopic examination to establish whether there are malignant cancer cells or bacterial infection. Immunofluorescence is performed under a microscope using a fluorescent light or dye to detect antibodies. Patch testing is performed to identify substances to which the patient has developed an allergy. Small amount of allergens are applied to the skin, and pruritus, which is itchiness, redness, or blisters or rashes may be noted. And scraping is a diagnostic test that allows you to scrape certain parts of the skin to identify fungi or parasites. Integumentary assessment on cellulitis. Cellulitis is caused by a bacterial infection. The bacteria enter the skin and releases their toxins in the subcutaneous tissue, causing an inflammatory response. Signs and symptoms. On the skin, the nurse will see redness, warmth, edema, pain, fever, and it could be tender to touch. The redness may spread and may not be even and often skip areas and eventually develop an orange peel appearance. Diagnostic testing. Because of the bacterial infection associated with cellulitis, you might notice the white blood cell counts are elevated, and then a culture will reveal gram-stain positive microorganisms. There are no typical x-rays done for cellulitis. If the x-rays or MRIs are done, it's because the physician wants to know the extent of the infection, such as have the infection spread to possibly the bone. And then you have medical and nursing management. The physician may order intravenous intravenous antibiotics and dressing changes. The nurses will manage the patient with cellulitis by giving the intravenous antibiotics and dressing changes as ordered. And then the education should focus on preventing and recurring episodes. Integumentary assessment on peripheral artery disease relating to skin changes. Arterial disorders cause ischemia and tissue necrosis secondary to narrowing or stenosis of the lumen, causing a decrease to no blood flow to the tissues. Examples are thrombosis, which is blood clot, and causing obstruction or an aneurysm, which can cause a rupture. Nicotine, high blood pressure, and diabetes are all high risk factors for developing peripheral artery disease. Signs and symptoms. Patients with peripheral artery disease have uneven pulses, and a Doppler is sometimes used to detect the pulses. The skin appears very shiny, and the ulceration has a very distinct circular border edge. Because of the ischemia, the patient does also experience the 6 P's, which is pain, pallor, pulselessness, paresthesia, polycythemia, which is coldness, and paralysis. Medical and nursing management. Doctors will consider various medications, one being a vasodilator. For the pharmacological management, vasodilator inhibits platelet aggregation and attempts to restore the blood flow. Nurses will educate patients on smoking cessation, avoiding trauma to the area, and avoid long periods of standing, and proper education on his or her diabetes. Again, as a reminder, nursing taking care of patients with peripheral artery disease may not be able to palpate their pulses. Therefore, a Doppler may be used to detect pulses in their distal extremities. Integumentary assessment, peripheral venous disorders relating to skin changes. Venous disorders cause reduction in venous blood flow or a reflux of blood through the valves, causing blood stasis. Venous stasis is a condition where the blood is not returning to the heart. This may then cause a host of problems, including coagulation defects, edema formation and tissue breakdown, ulcers, and an increased risk of infections. Risk factors include a history of varicose veins, heart disease, and obesity. You have signs and symptoms include heaviness, pain, tenderness, redness, and edema. Medical and nursing management. Management of the patient with venous insufficiency is directed at reducing venous stasis and preventing ulceration. Nurses need to encourage and educate patients not to use tobacco, as we need to encourage all patients. Nurses need to encourage and educate patients to wear shoes, compression stockings, stay out of hot tubs. Ambulation is beneficial, and encourage elevation of their extremities when sitting and laying down. Nurses also need to educate and encourage and teach patients to check the soles of their feet. Oftentimes, these patients can't reach the bottom of their feet. Therefore, nurses may need to teach the patient to use a mirror or have a caregiver to hold the mirror to assess the soles of their feet. It is very important to do a complete assessment of that skin in that area. Integumentary assessment regarding stasis ulcers. Stasis ulcers is the inadequate exchange of oxygen and other nutrients in the tissue, affecting the cellular process, leading to ulcers and eventually to necrosis, which is cell death. Chronic venous insufficiency can associate with stasis ulcers. Stasis ulcers are usually in the lower extremity towards the ankle area. They are characterized by irregular borders. One complication that may occur with stasis ulcers The patient may develop cellulitis, which we have already discussed. Symptoms may include pain at the site, irregular borders, redness, open areas, and it may weep. Medical and nursing management. Patient with ulcers may be effectively managed by advanced practice nurse or a wound ostomy nurse in collaboration with the patient primary provider. All ulcers have the potential to become infected. Nurses would need to encourage the patient to keep their legs elevated, encourage increased ambulation, use of compression stockings, which help with venous return. Anything nurses can do to encourage venous return, encourage patient if they note any signs or symptoms of infections, they need to contact their medical physicians. If it does become infected, again, they may need IV antibiotics, dressing changes, and that will be determined by the primary physician as well as the ostomy nurse or advanced practice nurse. Again, this is a nice chart provided to determine the differences between arterial and venous ulcers. Again, to recap, arterial ulcers have that circular, punched out, well-defined edges, whereas the venous ulcers have that irregular border edges, and it's more towards the ankles. Infections and skin disorders such as fungal infections are discussed in your book, which you need to take a closer look at. Fungus is a skin infection that affects the skin, the hair, nails, in other cases internal organs that may be life-threatening. Please review the tinea chart. For example, tinea penia is a foot infection or athlete's foot. Tinea can affect the head, body, groin, feet, and nails. Candidus, this is an oral fungus or sometimes referred to as oral thrush. Candidus or oral thrush is caused by the normal flora of the oral cavity is depleted because a patient may be on antibiotics or chemotherapy. Management for tinea penia, the physician may order antifungal creams or ointments for athlete foot. For the oral thrush, the physician may order some medications that the patient can swish and swallow or swish and spit out, depending on how the physician orders it, because thrush can travel through the GI system. Regarding bacterial infections, skin disorders, nurses must know primary skin infection versus secondary skin infection. For example, impetigo is a bacterial infection that affects healthy skin. That is considered a primary skin infection, whereas secondary skin infection affects the skin that's already broken, so further damage is seen due to the skin already broken. Impetigo begins as a small red macule, then changes to a vesicle that bursts and become covered with a loosely honey yellow crust. Impetigo mostly affects the body, the face, the hands, necks, extremities, but can spread to other parts of the body. You may see other symptoms such as itching or the scratching of the affected areas. Staph aureus is the most common host or bacteria of impetigo. It is contagious by contact, and the treatment is antibiotics, systemically or topically. Because impetigo is contagious by contact, nurses do need to practice and educate patients and patients' family on good hand washing and wearing proper PPE. With regards to viral infections, skin disorders, your book discusses various skin disorders. We're going to look at the herpes zosters, or what we call shingles, and herpes simplex. Shingles are an infection caused by the varicella zoster virus. After a case of chickenpox, which is the same varicella virus, will run its course, the varicella zoster lies dormant inside the nerve cells. When reactivated, the virus multiplies and creates this painful fluid-filled blisters and create a red rash along the area of distribution of sensory nerves. Oftentimes with shingles, the client would experience the pain before they ever experience the rash. In the PowerPoint, the photo does give you a illustration of shingles. But again, oftentimes the patient will experience the pain first and then the rash. The difference between chickenpox and shingles is that chickenpox in its true chickenpox form is airborne precaution, and shingles is in contact precautions. Patients are placed on contact isolation with shingles because the varicella virus lives within the fluid inside the blisters. The blisters needs to be covered at all times when it's draining. Again, the patients usually experience pain during the whole process. Even after the rash is gone, patients can still experience pain. Nurses must consider use of pain medications. Oftentimes, the physician might put the patient on an oral antiviral medication, as well as medications to target specific nerve pain caused by the shingles. The medication is called Neurontin, and there are other medications as well. And again, to recap, these patients are placed on contact precautions for shingle viruses. And you can do a self-study for herpes simplex, and it has to do with the virus in the mouth or the genital areas. Your book covers parasitic skin infections, and we're going to cover scabies and pediculosis. Scabies or mites that burrow underneath the skin, and sometimes it takes up to 4 weeks before the symptoms start. Scabies is an infestation of the skin by the itch mites. The disease is most commonly found in people living in poor hygienic conditions and in people who are sexually active. They're also seen in older adult patients living in long-term care facilities, and they are very vulnerable to outbreaks of scabies because of their close living areas, their poor hygiene due to limited physical abilities, and the potential for incidental spread of the organisms by staff members. The mites may create multiple burrows that may involve the fingers, the hands, the wrists, elbows, feet, and other areas. Patient may experience extreme pruritus or itching that may last for weeks. One classic sign of the scabies is an increase in itching that occurs during the evening hours. And that's perhaps because the increased warmth of the skin has stimulating effect on the parasites. Medical and nursing management for scabies. Physicians may treat this with anti-parasitic cream, corticosteroids, or an oral antihistamine to control the itching. Patients may develop a secondary infection from having itch mites or scabies. So if that occurs, then physicians and nurses will observe for signs and symptoms of an infection, such as increased white blood cell counts and positive blood cultures and then the physician would treat that with antibiotics. Nurses will assist and educate the patient on bathing, having clean bed linen, clothing, and apply anti-parasitic cream, and then give them an antihistamine medication to control the itching. Pediculosis capitis is the infestation of the scalp and the head lice. What happens is the female louse is the singular, and what she does is lay her eggs, which is called nits. The nits attach and stays on the hair shaft for about 10 days, and then it hatches, causing more lice. Lice is more plural. So pediculosis needs to be in contact precautions because it's spread by contact. It is spread by contact through bed linen, clothing, brushes, hats, anything, you can name it. Nurses need to give a very good instructions to the parents, caregivers of the children, or adults, because this is not just restricted to children. Patients do experience a lot of itching, obviously, in the scalp area due to the head lice. They can be treated with medicated shampoos. They do need to use a medicated shampoo and use a fine tooth comb to remove the nits so they do not have the chance to hatch again. They also need to be retreated again about 10 days later to prevent hatching again of the nits left behind. Please do not stereotype these. Please do not stereotype, because these bugs like clean hair and not necessarily due to uncleanliness. To get rid of the lice and nits, a mega cleaning of the house must be done. Any brushes, combs, and small items can be soaked in boiling water to kill the lice or nits. Bed linen and clothing can be washed in hot water. Stuffed animals, hair things that can't be washed can be tied up in baggies and sealed in a plastic bag for about 30 days. Non-infectious inflammatory dermatosis, also known as dermatitis. Dermatitis is an inflammatory reaction, usually due to a physical or chemical agent, what we consider as eczema. Signs and symptoms of eczema may include pruritus, burning, redness, and swelling in that area. You may observe papules and vesicles. The papules are about less than 0.5 centimeters in size, and the vesicles are the serous fluid filled areas, and those are again less than 0.5 centimeters in size. Treatment for eczema, dermatitis. The physician may order for the nurse to do a moist dressing to soothe the skin. The nurse needs to educate the patient on removing the irritants. So whatever is causing the inflammatory response, whether it's physical or chemical agents, we need to remove those irritants. Both rosacea and psoriasis are self-studies, and I would recommend the students to read those areas. For psoriasis, students need to focus on signs and symptoms such as itchiness and scaly patches. Student needs to know that psoriasis can be stress-induced and it can get worse with increased stress. Skin cancer will be discussed more in depth in MedSurg 3. In this class, we are providing you with the basic information. Nurses need to be able to identify or look for danger signs such as lesions or pigment of the skin. Nurses must identify that if a lesion is asymmetrical, it is a sign of melanoma or skin cancer. Nurses must assess the lesions by looking at it according to the ABCDs. A being asymmetrical, B meaning border and irregular, C for color variation, D the diameter larger than 6 millimeters in size. These are all characteristics associated with skin cancer.